Hello and welcome everyone to another Macular Degeneration Association virtual program. If you enjoy today's program, we will be recording it and we'll have options to listen to it later on our website. We also have many other virtual programs planned for this year, so please check back to our site to see those dates as well. And we're happy to announce that we are going to be having some in-person dates as well. All of these can be found on our site, www.macularhope.org. So we hope that you find yourself there and find other dates and even come visit us in person at some of those dates. So today we would not be able to bring this program to you without our generous sponsors such as Regeneron, Apellis, Ocular Therapeutics, Merck, and Notel Vision. We thank them for their support of these and many other programs. Following today's talk, we are going to have a Q&A session so you can ask your questions of the doctor. We do ask that you use the Q&A function of the bottom of your screen. If you do not see the Q&A function, you may have to click the More box, and the Q&A box will appear there. We will not be taking hand-raised questions, and we will not be able to hear you if you try to comment. So please place all of your questions as soon as you think of them into the Q&A box. They will be sitting there waiting and ready for you when the Q&A section of the talk starts. But without further ado, it's now my pleasure to introduce Dr. Mohammad Rafieatary. He is a consultative optometric physician who has dedicated nearly 3 decades to his career to the Charles Retina Institute, where he has been in practice since 1996. Dr. Rafieatary earned his undergraduate degree from Boston University and went on to receive his Doctor of Optometry from the University of Missouri, St. Louis. He holds dual board certifications from the American Board of Optometry and the American Board of Certification in Medical Optometry, and is licensed to practice in 5 states: Tennessee, Mississippi, Arkansas, Kentucky, and Texas. Throughout his distinguished career, Dr. Rafieatary has become a recognized voice in the field of eye disease with a particular focus on conditions of the retina and vitreous, and has been published in numerous professional journals and is a sought-after lecturer who shares his expertise widely with the medical community. His talk is titled Latest Insights of Age-Related Macular Degeneration. Dr. Rafieatary, you have our attention.
Thank you very much. Thanks for that nice introduction. I need to have you come with me at different meetings because hey, that was one of the nicest introductions I ever had. Good to be here. I'm glad you all have a few minutes. I'm in between seeing patients this morning, so actually at a clinic in Mississippi. So we're going to start talking about macular degeneration and demystifying hopefully some of the misgivings and giving you some basic background information about it. So let me see why my slide is not. There we go. So what's macular degeneration and who is the elephant in the room basically? So it's a common condition. Approximately 20 million Americans past the age of 40 have age-related macular degeneration. So I compare it to my patients when I see them, because when you tell people that have macular degeneration, there is this fear, because there are family members who have lost vision from macular degeneration. There are, people hear this in common media and things like that. So everybody fears. For one thing, macular degeneration is not a blinding disease. People don't go blind from it, but you can lose vision. But not everybody does. Most patients who have macular degeneration, in fact, many patients may live with macular degeneration and never know they've had the disease. But in some cases, it is progressive. It depends on the degree of progression as to how much vision you lose. What are some of the risk factors? Of course, aging, genetics, lifestyle, health status, these all play a role in somebody who develops macular degeneration, but also in the progression of macular degeneration. Because again, it doesn't progress the same way. So one of the most common questions I hear, in fact, yesterday, a patient with his wife, and the wife is asking me, can you cure this? Why can we not cure age-related macular degeneration? We live in the 21st century, and there are all these modern medicine and modern technology. Why is it that we cannot cure macular degeneration? And this story comes in my mind. Of course, I was not born in the US, but I came as a young lad. I was 17 years old in 1977 when I came to the US. And I came near the time frame. I can't remember if it was Memorial Day or Labor Day. Some of you may remember this gentleman, Jerry Lewis, had a telethon. So I came to the US. My brother was already living here. I turned the TV on. Jerry Lewis is on. There are people, entertainers. They're talking about something. Then I turn off the TV. Back in those days, we only had two or three channels. I turn off the TV, go get breakfast, come turn the TV back on. Jerry Lewis is on. It's lunchtime. Jerry Lewis is on. It's dinner time. So I told my brother, I said, is this TV only shows Jerry Lewis? He said, no, he's raising money for something. My brother didn't know what he was raising money. He was raising money for muscular dystrophy. And look at these numbers. Look how many billions of dollars this gentleman raised for a condition called muscular dystrophy. And he wanted to cure this condition. Muscular dystrophy, do we have a cure for it today? Not really. See how much money was raised. But there's some, if you look at the literature, if you look at the internet, there are some advancements into this disease. One of which is not a uniform disease. There are multiple forms of this condition. There are different names for it. But it's interesting, if you look on the bottom of this thing, let me see if I can put this thing on here so y'all can see. I hope you can see if you look at bottom of this thing, I don't know if you can see the marker or not. Those companies that are doing like clinical research, some of them are actually the ones that are doing clinical research for age-related macular degeneration. So age-related macular degeneration is not unique in a disease state that's fairly common, affect certain people, but we don't have cures, but we have hope for cures or hope for advancements in technology. Now, I don't know why my technology is best until it doesn't work. You close this thing, maybe I can advance my slides. There we go. So age-related macular degeneration is a spectrum. Patient starts at with healthy retinas, and it goes to you don't have macular degeneration, then you have normal aging changes, then you have early macular degeneration, and clinically we classify these by what size this word drusen, I talk about that, what size drusen you have, which are these yellow deposits that form under the retina. They're the byproducts of the mechanics of the retina, that this layer under the retina called the retinal pigment epithelium that's supposed to clean this stuff, and it fails to clean it. And when it fails to clean it, this stuff accumulates. In that second image on the bottom, you can see that yellow spots in the middle of the field. The first one, the macula is normal. The second one, the macula is showing some changes. The third image, there's more changes. And the fourth image, you actually see bleeding in the middle, what we call the macula. So that's very advanced form of what we call wet macular degeneration or neovascular macular degeneration. Does everybody reaches that? Not really. But it takes several years going from normal to early stage to what we call the intermediate stage. Once you go to that intermediate stage, then it's a slippery slope. So some words we need to talk about. First of all, what is macula? Macula is the middle 5 millimeter or the 2/10 of an inch of the back of the eye. We call it the retina. So the entire back of the eye is called the retina. The retina has some area, so that yellow circle I have in that picture is basically your macula. And in the middle of that, you can see that yellow stuff. And then that yellow structure to the right, that's the optic nerve. That's what carries information from the retina to the brain. We actually don't see with our eyes, we see with our brain. So a lot of patients have visual problems. Part of that is caused by the brain. Part of that is by the brain's ability to decipher poor images that come from the eye or not. So we cannot always blame the eye itself for loss of sight. It's just like hearing, walking, all those functions are basically run out by brain. Drusen, you hear this word often, maybe when you go to your doctor and they're examining you, they tell their scribes that they are seeing drusen. What is drusen? Is these yellow deposits, like I said, is waste material basically from the retina, photoreceptors. That scan you see down there is a normal scan of the middle of the eye. So if you look at that white line on the bottom, in the middle of that picture, that white line that goes across, that's the retinal pigment epithelium and the photoreceptor complex. So that's normal. And in macular degeneration, it looks like this. So you see these bumps and lumps. So the early indication clinically for us to see if patients have macular degeneration is these bumps and lumps that forms in that white line, which what we call the retinal pigment epithelium. So that tells us that the patient may have macular degeneration because you could see those bumps and lumps, as I showed in that box earlier, as an aging, age causes that stuff too, but not, I have this expression that if my uncle has a mustache, not everybody with the mustache is my uncle. So drusen is part of the macular degeneration spectrum, but not everybody but drusen has age-related macular degeneration. In fact, drusen can be formed in other form of retinal problems. Some of them are benign. We have a condition called familial or inherited drusen where people just have these yellow spots, and most of those people never have any problem. So there are other things that could happen. What happens with classification? Also, like I said, everybody almost starts with early on, and then they go to, mild disease and symptoms of that may, some patients may say, it's harder to see at night, the contrast is not there, my vision eroding. The signs of this disease may differ from patient to patient from the degree of amount of drusen they have, the pigmentary changes they have. It takes time to go to that intermediate AMD, where from that point on, uh, things change. But this is the problem with classification. So you tell 5 people you have intermediate age-related macular degeneration. That's like telling 2 people you're multimillionaires. To be a multimillionaire, you have to have $2 million. But then if you have $20 million, you're a multimillionaire. If you have $200 million, you're a multimillionaire. But it's intuitive to know there's a difference between having $2, $20, $200, and then $2 million where you're a multimillionaire and not $200. So there are some patients in that intermediate age-related macular degeneration that in that $2 million category, that's a lower degree of disease. There are people who are in that $20 million, and there are people who are in that $200 million. The connotation of that is the larger amount of the disease you have, the more chance of you having problems. Your vision can deteriorate just from the fact that you have so-called dry macular degeneration. But then you could have those advancements of what we call geographic atrophy and neovascular macular degeneration, and those could happen together, and that what really causes significant central vision loss. Again, I've done this for 40 years. I've practiced nearly 40 years or been in eye care. And for the last 30 years, I've been basically in the back of the eye, in the retina. And back in the days, 30 years ago when I started this, we didn't hardly had any significant treatments. We had laser treatment and some patients qualified. So in some 30 years, I've probably seen 5 patients who are completely blind from macular degeneration. 2 or 3 of them was in the early phase of my career where people bled really bad. But a few of those patients back in the days, they used to do surgery to remove these scar tissues or blood vessels that develop from neovascular or wet macular degeneration. And in doing those surgeries, a few patients went blind during surgery. So you couldn't really blame the disease. You could blame a fix for the disease. That was not a good fix. And that's why back probably in 1990s, between 1996 to 1997 or 8, our senior doctor was doing some of those surgeries and he stopped because we did a literature search on everybody who had those surgeries, and most patients were not being helped, and some patients developed bad problems. So we stopped doing those surgeries and resorted in just lasers in limited case. And then in late 90s, early 2000s, then other treatments formed and the injections came about. And right now we are still in that injection phase. So what are some of the risks? What are some of the things you can do to either prevent the disease, which is not really preventable? If your genetic makeup is set for you to have macular degeneration, you can have macular degeneration, but you can maybe delay it, and more importantly, you can delay the progression or reduce the progression by not smoking, by eating healthy, by exercising. You know, you cannot help the genetics of the disease, but there's something called epigenetics. Epigenetics are the stuff that happens in our environment that doesn't necessarily change our DNA in our gene, but it changes how these DNAs and things like that work. So people like you hear people who are exposed to toxins like asbestos or different paints or lead or things like that that develop disease based on those toxicities. So that's epigenetic changes. So the environment you live in is very important. The lack of exercise. Medical health is very important. Things like sleep apnea play a role, hypertension, cholesterol. So the best thing is to help with this disease, not to smoke, eat healthy, exercise, and make sure your medical problems are checked. And if you have any medical problems, that you're dealing with it. Now, one other way for us to know the if somebody has macular degeneration or somebody has risk of progression is by genetic testing. And genetic testing is not is become much more simpler. All you do is you either take some blood or take sputum in a tube, or the easiest way is to brush the gum, put it in a tube, send it to a lab that does this type of genetic testing, and then they send you the results back. We don't recommend those, offered to the public genetics. So if you want to do genetic testing for macular degeneration or inherited retinal disorders, we recommend those being done by eye care providers who provide this type of services. So, like I said, they're becoming more and more accessible. Sometimes there is a cost to the patient because not all insurances cover this, but it's becoming much, much easier. What are some of other ways we can do risk assessment? Is by the findings. So this stuff we call drusen that I mentioned, showed you pictures and described them, it comes in different sizes. So like 125 micron, which is a tiny spot still, is considered to be a large druse or drusen. So this risk assessment table came as a result of the ARED studies. You all have heard probably to take the ARED vitamins. Those came from the age-related eye disease study that looked at the value of certain nutritional supplements for reducing the chance of progression of age-related macular degeneration. So they say if you have large drusen in one eye, pigmentary change, that pigment layer is changing and releasing its pigment. So the retina that's supposed to be transparent now is getting brownish granules to it. For each one of these, you get a score of 1. So if you have all 4 of these in both eyes, you have a score of 4. That gives you a 50% chance of conversion from dry to wet macular degeneration in 5 years. There's still 50% chance of not to. So what are all those chances, like the 3% chance, 12% chance, 25% chance? Again, as this thing progresses, the likelihood of going from dry to wet macular degeneration and also to develop geographic atrophy increases. So that behooves us to follow the patient close, because you cannot always rely on the patient to knock at the door and say, I've had a sudden change. Sometimes it happens, many times it doesn't. So if your doctor sees these, they have to go, well, I used to see you once a year, now I want to see you every 6 months. I used to see you every 6 months, now I want to see you every 4 months. I used to see you every 4 months, now I want to see you every 3 months. Once you get to those levels where, God forbid, you need those injections, then you're going to be seen a whole much more frequently. Some patients every month, some patients every 6 weeks, some patients every 2 months. But most often we don't go past those every 2 months. Depends on what medication you are also getting for those injections per se. So that's part of the reason the frequency of the visits may change because of the progression of the disease. So again, how do we, what are some of the telltale signs? Do we rely on the patient to tell us they have macular degeneration? Is it based on what you tell us? Is it based on what we see? What you tell us as patient to a doctor, we have to listen, but it's not always reliable because often your vision changes in a very subtle way, and you may not notice those subtle ways. We do this thing called visual acuity testing, that the 20/20, 20/30 connotations that patients get really proud when they see 20/20. In this disease state, those numbers don't really, you could have bad macular degeneration and still see the eye charts really good, one letter at a time. You could see one letter at a time. So if you're looking at my face, you could see my nose, that's one letter. You could see my um, right eye, that's one letter. My left eye, one letter, but you cannot see my face. That's bad macular degeneration, where you can pick and choose things, but you cannot form an image per se. So we do risk assessment. I don't know if this tape is gonna run or you could hear this gentleman, but I'm gonna press my button here and let it run. But this is an example. This in fact, it was in this clinic where I'm today in Oxford, Mississippi. I walk in the room. These pictures are on the wall of the patient, and the patient has 2400 vision. What does that mean? Is a letter that a normal eye should see at 400 feet, but a patient has to walk from 400 to 20 feet to see this letter. That's what those designations are. 20/20 in the other eye. What does that mean? Is a letter that designed for you to see at 20 feet, and you do see it at 20 feet. So that right eye that's got 2400 has a huge hemorrhage from macular degeneration. How was this
So how
discovered?
did you find that you can't see?
My granddaughter found it,
How old is she?
6 years old.
Oh my God, how did she find it?
She was playing eye doctors at the house one day, and she backed off a little ways and told me to close my left eye. And she helped up some fingers, and I could not see her fingers. And that's when I noticed it. See, my right
And
eye,
then you went to see the eye doctor right away, or you waited?
I waited about a week till I could get there. But I can see well out of my left eye.
I'll go over your pictures with you and go over your condition.
So I hope you heard this, but this gentleman was totally oblivious to this massive loss of vision in his right eye. His granddaughter, who's 6 years old, goes, "Grandpa, I want to play the eye doctor. So close your left eye," and he can't see the fingers. And now he's 3 times he tells me he sees well out of his left eye. His left eye has intermediate age-related macular degeneration. And in fact, he's got large drusen. He's got some pigmentary changes. What does that mean? In the next 5 years, he could potentially have developed the same problem. So that right eye problem happened and kept on going and going to the point that even though he had a few injections, we couldn't really improve his vision much. We could just stop this bleeding from taking over and over and becoming one of those situations, like I said 30 years ago, where I saw people bled so much that their complete or most of the vision was gone. So he can't see with the center. But 3 times he's telling me there's nothing wrong with my left eye. That message to me as a doctor is, let me go. I still have a good left eye, where you really don't. So I told him at the end of it, I don't know, I hope you heard this. I said, let me go over your pictures and your findings. So I examine him, show him his pictures, like, sir, you have problem in the left eye too. We need to keep a close watch on you. You need to take your vitamins. If you smoke, you need to quit smoking. You need to be more cognizant. Part of the trouble with macular degeneration, even in healthcare, this was a paper that was published in 2017. What happened was they took 600 plus patients and had both optometrists and ophthalmologists, because sometimes patients think, oh my God, I should go see an ophthalmologist. We all have good, bad, medium-sized doctors. I mean, it doesn't matter what profession you are. So they had these patients examined by general ophthalmologists and optometrists and said, tell us who has macular degeneration and who doesn't. So they took those charts of the patients who were said they don't have macular degeneration, and took a picture of them and looked at the picture. 75% of those patients actually had macular degeneration. And more importantly, about 30% of them had intermediate macular degeneration. So if you're just looking at the patient physically, you could easily miss this disease because it could be very sudden. And if you do photography and scanning and all that, even during some of those, you could miss this. This is no different than the stories that you hear that somebody goes to the ER and has chest pain and they tell them you have indigestion. No, don't worry about it. They do EKG. EKG is normal. The person goes home and has a heart attack. So sometimes, it's the mystery of healthcare and medicine. Sometimes we can easily miss stuff. Sometimes we overdiagnose stuff. There are many macular degenerative diseases that are diagnosed as age-related macular degeneration. In fact, they are not. There may be 20 some odd conditions that are very similar to each other. So those are our difficulties. Then what do? We have testing. Like I said, this is one of the most, like, since the 1800s, these charts existed where you have the patient look and read the letters. And it's a good way to test you to see if your eye is in and out of focus. We still have to do it. It's a standard of industry. If you don't document the patient's visual acuity, we call it, in some of the electronic health records, you cannot even go forward unless you put in a number in that box that says what's the patient's acuity. But part of the problem with it, we do it at the very first part of our examination, so we already bias ourselves. If you see that those letters good, we might not think you have a disease. And if you see those letters bad, we might think your time is up. There's nothing we can do about it. And there are other ways to do that. There are reading, there are, low luminance, what we call, to lower the light from it to see how well you can see. We have contrast sensitivity. We have ways to check your visual function by what we call visual field, either by very localized or diffuse. We have this chart. This chart, for instance, is a good chart if you take it home and do it. But most patients don't do it. I have a lot of patients, I hand these charts to them and they, the next time I'm like, do you have that chart? What chart? They don't remember. Now, it's a good test at the chair side when the doctor does it, but it fails when you take it home because, like I said, many people may not understand it, may not do it. So for home device, the gentleman early on said one of your sponsors is Notal Vision. They have a home monitoring device. If you subscribe to that, they send you an instrument that you look into every day and it reports on you what is your visual performance, if you're seeing distortion without even you noticing. There are a few more other applications on the phone that I've developed that does the same thing. So there are some home monitoring devices. You may want to talk to your doctor about those next time you go see him. But some of these tests are not specific, So if you do a visual field test and the center part is missing, it doesn't necessarily mean it's from age-related macular degeneration. If your vision is poor, it could be from dry eyes, cataract. So, but we put these things together, your functional test and then what we call structural tests. We have, one of our advantages in eye care is we have really good imaging devices and we have easy access to the eye. Unlike the heart, that if you want to do a heart cath or something like that, is a little bit more invasive, but when you want to deal with the eye, we can take a photo camera and take a picture of inside the eye. We have the scanning devices. I'm sure when you've gone to see your doctors, many of you have this test done. And these tests give us a lot of information. But again, they're not panacea. There is positive and negative. There are pluses and minuses to every one of these tests. And we don't always have the luxury, not only by timing, today in this clinic, which is a place about an hour and a half drive for me to here and back, I have 50 some patients. So I have to come see all those patients and get in my car and drive back home. So we don't have the luxury to do every one of these tests and sit back and scrutinize and see what's going on. So we have to pick and choose what test serves what patient the best. So those some of the criteria. Now, how do we treat this disease? You know, when we tell somebody you have macular degeneration in the early stages, I say this over and over. It's just basically a lifestyle suggestions: don't smoke, eat healthy, exercise. But for the most part, our treatments of the past with age-related macular degeneration has been reactive treatment, you know. So if these messages of eating and smoking and all that, honestly, if you have macular degeneration, start that with your grandchildren and your children. Because I have patients, particularly in this clinic, when they come see me and I say, quit smoking, the 80-some-year-old gentleman has been smoking since he was 14 years old. How much do you think he's going to listen to? And how much damage that smoking is caused by now? The dietary habits been bad since they were born, so they're 90 years old now. So what difference does it make if I change their diet? So many of these are cultural stuff we have to start from early on. People who have macular degeneration should talk to their children and grandchildren and say, do this stuff so you don't end up like me. That's part of what we have to change in our culture. So, and take care of your health. You know, tell your friends, tell your community, become the poster child for this disease. If you're suffering from this, it's hard that you're suffering, but you need to help others not to suffer as well. You know, also don't forget about your eye examination. Even if you don't have these conditions, you know, there are many forces that are working against us. These kiosks in shopping centers, people are trying to do the, you know, leverage the actual physical examination to other forms, but we cannot overlook the importance of a good eye exam at least once a year or so. Once you reach age of 40, you know, most of us lose our reading vision. So we get forced to see the eye doctor, but just don't go buy a pair of reading glasses from the drugstore and ignore the health of the eye. So that's very important. But for the most part in AMD, our treatment in the past has been reactive. You have to wait till you get to that intermediate stage, then you recommend the AREDS2. Then you wait for the patient to develop wet macular degeneration, and then you inject. Or geographic atrophy, which many years ago we didn't have treatment. Now we have these treatments to slow down the progression. They're injections, but to slow down. It doesn't stop it, it doesn't reverse it. So we are reacting to it. You know, now we are thinking more about the chemistry of this, more than the, you know, so there are formulation of these antioxidants and supplements that you can try earlier. You know, the Bosch and Lomb recently introduced the AREDS3. The AREDS2 was for intermediate and on. Maybe the AREDS3, because it's got a lesser zinc, you can start it a little bit earlier, you know, and it's even if you don't have macular degeneration. We used to tell patients, if you don't have macular degeneration, don't take the AREDS2 because it's got a lot of zinc in it. So to keep the chemistry of the retina healthy, will keep the structure of the retina healthy. Then we also have this new technology called photobiomodulation. Photo means light, bio means life, modulation is alteration. So as an example, how do we make vitamin D? We have to have sunlight. So light plays a big role. You know, photosynthesis on leaves and trees need light to do. Even some deep sea fishes and animals that don't have access to light develop their own light biochemistry. So light is very important. So this is an instrument that's FDA cleared, has a clinical trial that exposes the eye to certain levels of light, and those certain level of light excite certain elements of the cellular part of the eye to reduce what we call oxidative stress, to reduce inflammation, to improve certain, again, this is a chemical reaction. Everything that happens in your body happens by the chemistry of that. to change the chemistry of the photoreceptors and the what we call the retinal pigment epithelium to help with the health of these. There is a little logistics to this. That when you do it, you have to do 9 sessions in 3 to 5 weeks. It's about a 5-minute non-invasive way, but you may need to find a doctor in your area to do this. So then we have this, when you go to more of the advancement of this, let me make sure I'm not running out of time. You got geographic atrophy. Geographic atrophy also very common. Is not a different kind of macular degeneration, is an advancing of macular degeneration. It's common, it's progressive within 2.5 years from the diagnosis of it, is encroaches to the center and start eroding the disease, is not reversible. So what causes this? Part of it is nature, part of it is nurture, but for the most part, one of the things that been identified to cause this is the genetic variation of something we call the complement system. Complement system is part of our immune system that's supposed to get rid of bacteria and dirt and stuff in our body. So I compare it to a vacuum cleaner that's supposed to clean your carpet. In macular degeneration patient, this system becomes overactive. So not only it picks up the sand from your carpet, but it starts sucking the fibers of the carpet. So it's damaging to the system, or your own immune system is damaging the system and is eating up your healthy cells. So these two companies have developed injections that block this system to some degree, making it become less overactive. So you have less damage. So the goal of these treatments, and most of them are like once a month or every 6 weeks or so, is to slow down the progression of the disease. It doesn't stop it, it doesn't reverse it, but you can slow it down, that hopefully you give the patient many more years before their vision is affected by it. And then the other aspect of this is what we call neovascular, Age-Related wet AMD. That's when this scar tissue, this vascular scars form under the retina within that pigment layer and the retina itself, and it could cause scarring and all that. Back in the 80s or so, hot laser was available. In about 2000 or so, cold laser became available. But a whole lot of this didn't really work. So patients would end up with scar tissues like this. And they always said, why can't you remove the scar? And like I said earlier, a limited number of these scars were removed by our clinic and other clinics around the country, but it didn't really result in good outcome. Now, injections do help. So this is a patient, for instance, I've seen about 5 or 6 or 8 of these patients this morning. Patients who come here into this clinic and get injection, they do better than, like this patient as an example was doing better, then didn't want to have any more injections, said, I refuse, I'm seeing better. 3 months later, they come back and that middle image is an active disease. So you give them an injection, a month later, they come back, the fluid leakage, the blood is going away. If you leave it alone, most of them come back. So it becomes a continuous treatment. There are a number of different medications that can be done for this. Part of our dilemma in this, or barrier, is insurance coverage. Some of these drugs are, pricier than others, so we cannot always do them. Part of the problem with these drugs today that are getting injected, and that's why most patients have to have frequent injection, is because they don't have durability. It's like no different than insulin for diabetes or your blood pressure medicine for your blood pressure. If you don't take them, your blood pressure goes up or your blood sugar go up. So if you don't do these injections frequently, the disease comes back because the disease is chronic. So there are things in clinical trials to see, can we give medications that not only work better, but stay longer. So there are a whole number of clinical trials. Some of these have already been FDA approved. For instance, this picture you see is a port delivery system, is an implantable device that by surgery is implanted in the eye, and you fill it every 6 months. So it's almost like an insulin pump that's fixed to the eye, and you feel this. So the patient doesn't need to get monthly injection in most cases. Then there are other form of treatments in clinical trial. Some of them are genetic-based treatments where uh, genetically modified cells are put in a virus that doesn't cause you any diseases. These viruses are injected in the eye. They deliver these genes to the system that makes your pigment layer become a what we call a biofactory, a pharmacology factory. So you develop these medications or produce these medications yourself in that. This is an example of a patient of mine that in the left side, you can see that's the port that was put inside his eye, and his left eye got one of in clinical trial got one of the gene therapies where in single surgery, one of our surgeons put these viruses under his retina, which is a tricky surgery to reduce the burden of him having to have injections, and his disease got controlled by that. So in wet macular degeneration, our goal is to capture patients sooner than that gentleman that I showed you earlier. Same thing with geographic atrophy. The sooner you catch these diseases, the better chance you have to control them. And then one last thing is not to overlook low vision devices and our colleagues that do vision rehabilitation, low vision devices, because there are patients who, like this gentleman, is a case where he has 20/80 in one eye, 20/25, but even though he has 20/25, that's legal driving, he can't drive because he can see spots, he cannot see full forms. He cannot drive, he can still read with some difficulty. So a low vision doctor can give him magnifiers and things like that to help him with that function. So we shouldn't really overlook that. So one last thought before we go to a question session. I hope you all have some questions and I can check these. This is a very common disease. If somebody tells you have this, they're not telling you you're going blind. But if somebody tells you, a doctor tells you have macular degeneration, you need to make sure you get proper examination. You tell your family members because they have some risk. That doesn't necessarily mean they develop it. Macular degeneration from a genetic standpoint is a non-Mendelian disease. What does that mean is in Mendelian disease, when you have the disease, your children either have a 50-50% chance or 1 in a 4% chance, or some patients don't have a chance. It skips generation. This disease has multiple genes associated with it. So some people carry some of those genes but never develop a disease. Some people never had it in their family and they develop it. So you don't necessarily pass it on to your family members, but they have a risk. We need better public education about this disease, and that has to be funded by the government and some of the nonprofit organization, or even some of the pharma that have the medications for it. There have been several new innovations these days. When patients ask for a miracle for this, I tell them that these injections are a miracle because we didn't have these 20-30 years ago. And a lot of people lost vision as a consequence, and we don't have that much vision loss. And many of our patients are helped by these treatments, but part of it is the burden of them having to come back and forth. Some people are, at the age where it's not hard for them to travel. It's hard for them to come sit in an office for an hour and a half or two. So, but we have to deal with all this stuff. I thank you all very much. Let me see if I can see if there are any. I would assume there is a.
Yep, we got some questions. If you, I'm just going to stop your share.
So stop my share. If you don't mind, read those questions to me. It may be easier to read those and I'll answer them.
Sure, not a problem.
Try to answer them.
Are cataract and lens replacement surgeries worthwhile if the patient is in intermediate dry macular degeneration?
Absolutely. Even with some of the more advanced AMD patients, if you have cataract surgery, it could potentially improve your visual performance, as long as some or part or all of your vision loss is from the cataract. So if you have macular degeneration, if you have cataract surgery, don't expect to have perfect vision back. And also, there is this controversy of does cataract surgery make age-related macular degeneration worsen? In most cases, it doesn't. In fact, I think it was in one of the AREDS papers that was mentioned that it makes it easier for the doctor to detect macular degeneration. So if somebody says, "Oh my God, you didn't have macular degeneration before, and you have it now," it was missed before. Because especially if you have the yellow aging form of cataract, it blends those yellow stuff and we can't see it as well. So yeah, I mean, if you have significant cataracts, by all means, consider to have your cataracts removed.
Thank you. Can you have both wet and dry AMD at the same time?
Yes, everybody who has wet AMD has dry AMD. It's all starts with all those, the early and intermediate are a form of dry AMD. Now, geographic atrophy is an advanced form of dry AMD. So a patient can have both of those. And one of the problems we have is the injections that are for geographic atrophy, advanced form of dry AMD, increase the chance of wet AMD by a certain degree. Not, it doesn't necessarily cause it, but you could increase the chance of it. So those two stages of macular degeneration can be concurrently or together.
If you are receiving injections for wet macular, can they use that medication for the dry form to keep it from going to wet?
So I think the question is backwards. If you have, or let me put it this way, if you have dry or geographic atrophy and you're getting injections for that, let's say, and you develop wet macular degeneration, yes, you can have wet macular degeneration treatments. In our clinic, we don't do those at the same time. Some do. In our clinic, if you have the dry form and you're getting the injections for it and you develop wet macular degeneration, we might hold off your dry macular degeneration injection, give you a couple of injections for the wet one, bring it under control, and then resume the dry macular degeneration treatments. But then you might need injections with both, so you have to logistically go back and forth to have both those treated at the same time.
Okay. I know there are medications for geographic atrophy. Can these medications be used for dry macular?
So again, geographic atrophy is a form of dry macular degeneration. But if the question is, can I start those when I have intermediate macular degeneration not to have that? Nobody's tested that. Nobody's going to test that. But most importantly, your insurance is going to pay for that because you have to have geographic atrophy to qualify. And by FDA approval, those two geographic atrophy medications are approved in patients who have geographic atrophy caused by age-related macular degeneration because geographic atrophy type lesions can be caused by other disease. We have nearsighted macular degeneration. We have this other condition called Stargardt's disease, which is a macular dystrophic degenerative disease. So you have to have age-related macular degeneration. Now, when does your retina specialist decide to do that treatment? If it's too early or too late, that's case by case and by your situation. So make sure you get the advice of your retina specialist and even your optometrist or your general ophthalmologist to see if you're the right candidate, is it the right time? But no, you don't treat it, you don't get those injections to prevent it from happening.
Besides the photomodulation treatment, is there anything else available to slow down the progress?
So taking the supplements, not smoking, there are some like electrical impulse things that are being studied. There are other devices in red light or light therapies being studied right now. But right now, that's the only other thing that we at least offer in our clinic, the photobiomodulation technology.
Okay. For wet AMD, do you believe in injections only if bleed is detected, or scan or exam, or on some type of maintenance schedule? Also, does switching the specific injection help?
So these are good questions. So the pictures and scans and all that is to make sure you have wet macular degeneration. And most in macular degeneration, most often when you have bleeding, Because one of the challenges is like I've seen patients today, they're diabetic and they have macular degeneration. You see a couple of hemorrhages and you're like, is this from diabetes or from macular degeneration? Because although they all get the same type of treatment, but they have to know what you're treating. So those testing are needed to make the right diagnosis, but those testing are not treatment for your diagnosis. So if you have wet macular degeneration and you have hemorrhages, you need injections. Now, changing from medication to medication, some of that is driven by your insurance coverage. So some insurances, for instance, they do what they call step therapy. They want you to start with this medication, use it 2 or 3 times. If the patient doesn't respond, then they allow you to use others. But yeah, it's like anything else. It's like treating your blood pressure. Your medical doctor may put you on a blood pressure medicine, and you don't get enough of a respond to it, and they might try other like blood pressure medication. So sometimes we have to switch from medication to medication.
Okay. Why does it seem that there is not as much research going into dry macular as there is for wet macular?
There is a whole bunch of research going on in both of these, but part of it is honestly is easier to find markers for wet macular. In other words, if you do clinical trials for wet macular degeneration, you have a disease it's like fire started, you put water on it to put the fire out. So it's easier to prove something works in wet macular degeneration. In dry macular degeneration, the only way you can do it is to do things to see if things are getting worse or not. So it's harder to prove that something's working because you also have this force against you that how do you know that it wouldn't have done the same thing if you didn't treat? So like in for instance, in the 2 medications that got approved, they use sham, some people were getting fake, some people getting the treatment. They did that for a period of time until FDA approved it. When FDA approved it, you cannot experiment on patient anymore to put them on sham. You have to actually treat the patient. Then you have to sort of extrapolate what would have happened if we didn't treat the patient. So it's a harder clinical trial model as opposed to the wet macular degeneration, where you have an active disease, you treat it, and you either get a response or you don't. And if you get the legitimate response, then your medication gets approved. So it's an easier one to, and that may be the reason there is more clinical trial for wet macular degeneration.
I just saw
Although those two conditions are geographic atrophy and wet macular degeneration in population, they're almost the same. There's the same number of people who develop one or the other, and some of them have both.
Okay. I just saw an advertisement for the new ARIDS 3. Should I switch from ARIDS 2?
So if you have, and the opinion of that it differs between expert to expert. If you have intermediate AMD and above, and you're tolerating the ARIDS 2, you stick with ARIDS 2. If you're taking ARIDS 2 earlier than intermediate and above, so the indication for ARIDS 2 is if you have intermediate macular degeneration and more, or if you have mild macular degeneration in one eye, but the other eye has developed advanced macular degeneration, because that could happen too. The disease, although it's in both eyes, is often very asymmetric. You do the ARIDS 2. Recently, for instance, 2 or 3 of my patients, I switched from ARIDS 2 to ARIDS 3 because they have GI problem. In fact, last time I was in this clinic, a patient of mine came and said he himself has stopped his ARIDS 2 because it's giving him constipation. So I said, well, use the ARIDS 3 because it has a lesser zinc. But if you have early macular degeneration or you're worried about macular degeneration, the ARIDS 3 is safer in my opinion, and that safety is because of the degree of zinc in the ARIDS 3, because it's got a higher than what we require ARIDS 3. But if you have that degree of age-related macular degeneration, that's what the NIH recommends, and that's what we recommend to our patients.
This one is, I'm a diabetic and have diabetic issues in the eye and macular degeneration also. How can they treat this to keep my vision?
So you treat your diabetes, your blood sugar, and all that, and then again, quit smoking, exercise, take care of your health, and then talk to your medical doctor to see if they're okay with you, if you have intermediate AMD and above, or lower degree to see if they're okay with you taking those supplements. But run it by your endocrinologist or your PCP to make sure you're not on some sort of treatment that is, those supplements are and not advice in your case.
Okay. If my mom has this, how likely will it be that I will develop it?
To some degree is a crapshoot, so you have a higher chance, but not necessarily. So one way to know better is that genetic test that was, this company Visible Genomics has uh, this test that you can talk to your eye care provider to see if they want to obtain kits and run the test. So it tells you if you have the genetic, and it goes based on both your genetics and your whether you're a smoker or not, and your height and weight and all that. So other risk factors, because BMI plays a role too.
Okay. This one is, how do you know if you're RS and then it's spaced ISD doing all they can, and should one always get a second opinion?
Well, RS stands for your retina specialist. I don't know who your ISD is. Maybe your regular doctor. Well, that's a loaded question. So if you don't have any faith in the doctor you see, get a second opinion, or ask about the reputation of the doctor. So that's asking me like, how do I know my doctor is doing well? I don't know. Maybe next visit you buy me a plane ticket, I come go with you. But that's the only way I can answer that question. And on
Thank you.
that note, it's already 1 o'clock and I gotta run back to clinic and see patients. So if there are no more questions,
Let me just ask this one last one and then we'll end it there. Has gene therapy been approved for use or is it still in clinical trials?
gene therapy is in clinical trials, and most of the clinical trials for gene therapy, although there are a few things that are coming up, is really not to cure age-related macular degeneration. Is to make your tissue become a biofactory, to make the medications. The ones that are actively doing now is to give you genetic material into your system so your body, your eyeballs, not your entire body, but your eyeballs make these medications similar to what are injected.
Thank you so much, Dr. Rafferty. We thank you so much for being with us today, and we want to wish everyone a wonderful day. And we hope that you can join us for future programs. Please check our website at www.macularhope.org, where you can find a list of all of those available. Otherwise, have a wonderful day.